You gotta push the record.
I did. All right. Okay, welcome everybody. Thanks for showing up tonight. Good to hear from everybody. So, Dental Codology Consortium Oral Cancer Work Group, June 30th. Awesome. We are charting our future. And Patty has a great recipe for success for us in her cookbook. We're building success for dentistry, for our future, for our patients, for us. And just remember, I want to really point out, because I'm texting and getting a hold of Patty a lot, asking her questions. If you have questions, please don't hesitate. Send me an email or text. And if I don't have the answer, I know who does. So just don't hesitate.
Not always.
Well, most of the time you do.
I do my best.
And we are mentoring. Patty is teaching us to fish. She's not giving us fish. She's teaching us to fish. So, just a great opportunity we have to learn here doing this. I've learned so much already. And remember, you can do anything, but not everything. And thank you all for everything you're doing. And a reminder, don't be a cowgirl out there running the barrels by yourself. We're a team. Absolutely, teamwork. Teamwork makes the dream work, right? And just a reminder, here's all who is in our group. Make sure you have everybody in your emails and your phone contacts. I've got to get all the phone numbers put in mine. Thank you. Just another thank you. And if you didn't watch last week's recorded session, please go back and watch it. A lot of great information in there, and especially Patty's history lesson that she gave us some background information. Really, really good information there. So please go back and watch those. And, you don't have to sit like I was going through it today just to re-listen to them. You don't have to sit in front of it. You can fold clothes, empty the dishwasher, just turn it on and listen to it. So we all are staying on the same page. So plan for tonight is to go group by group and see what we have, see what we found and learned in this first week. And I don't think we need to go into heavy detail unless you think so, Patty, but give a good, broad overview of what we have found. So let's start with our resources and potential partners group. And Janet.
Can I take a step back a little bit? Because I think, first of all, we have Michelle joined us, and she was at ADHA, and I would love to hear how the whole thing went around the information we shared with her. And Janet, I want to hear your opinion. Lucy, were you there? Lucy?
No, I wasn't.
Okay. So we definitely want to hear from Michelle and Janet about ADHA, about the House of Delegates, what happened around oral cancer and the HPV. We know the end point, but if you guys can share a little bit about the discussion, it might help us to understand more what's going on.
Yes, awesome. Thanks, Patty.
I still don't have much of a voice. This is Michelle.
Oh, God, Michelle, you sound terrible.
Bless your heart.
It's been like this since Tuesday, so. And I think it was trying to get that legislation, PR through. Anyway, go ahead. Do you want me to say more? Or?
Yeah, tell us what happened.
Well, let's see. I, originally the House of Delegates, or excuse me, I'm trying to chew at the same time too. The Board of Trustees said to they didn't say to withdraw. They had me withdraw one because it was very specific, and then this one they said rejected. So we went back in and I had to do whatever my district was telling me to do or asking me to do. So we rewrote it again. And that's when I started reaching out a little further, because when I started this process, it was back in February before we even had this, this committee. So I was doing it pretty much on my own. And it all started because a member, card carrying ADHA member, wanted to know more and do more. And it was particularly with brush biopsies. So, but anyway, so we watered it down. And of course, they come back and say, we already have policy. And we
Can I ask where the specific policy on head and neck oral cancer screening is?
No, it's just the things. It's I don't have it in front of me. I'm sorry, I should.
No, it's all right, Michelle, because the only thing because when Susan and I were looking, the only thing I could find is we have something about assessment, complete assessment. But I don't see anywhere that we have anything about thorough head and neck oral cancer screening.
No, there is nothing.
Okay.
There is nothing. It's just assessments, and everything rolls up into one. And, and that's the way they like it. Very, very broad. And I said, with the advancement of all these advanced dental hygiene practitioners and all that, we need a more specific policy so that, these hygienists can go in and do these other things, and other states are doing more specific oral cancer screenings. And then there are other states like New York, they can't do anything. And there's, of course, worse states in New York too, but again, they wanted broad, and I said, we are going to be pursuing coding in this for oral cancer screening, and it would be nice to have some more specific policy. And pretty much they just said, well, if you ever need a letter of intent or anything, we can write a letter, but everything has to stay broad. But it's only when they want it to stay broad. There's other examples where they specifically, like, they wanted to add doctors in dental hygiene to make a point, because we didn't have it written that way. So that passed without any problem, putting in, associates and all that. But, when it suits their purpose, then it's fine. But if it's not in their agenda,
When you say they, who are you talking about?
I'm talking about the Board of Trustees, and we had some good support among the delegates, but not enough, because a lot of them are just as bad. They're very yes ladies to everything. And I even saw that with the student delegation. They're like, well, if the Board of Trustees said this is the way it should be, and this is the way it should be. So nobody is, questioning and trying to, I'm always good for stirring up some little bit of controversy, but but if some of the delegates are,
I hope you feel comfortable here, because that's what we do.
Well, yeah, I do, and our district has that problem of stirring up trouble, because we started all this stuff about the NOMCOM and all that try to get more nominations on the floor and all that. But anyway, what was I thinking? I was going to point something else out. I don't know. It's frustrating. I come home sicker than a dog.
Yeah.
but
Those meetings are long. Can I ask Janet? Janet, can I ask you your point of view? Because you were there. Were you there as a delegate for your state?
No, I just went and listened in on a lot of different things and attended CEs. I am not a delegate.
Okay. So did you attend the HOD?
Yes, I went to a couple of them. I think the biggest thing, they're afraid, like she was saying, to change things and make too much waves. There is a lot of, I think, people that have been involved a long time that, this has been working, why change it? I think they also hesitate. I'm sorry, I missed that.
I said, yeah, because we have perfection. Why change it?
Right.
Sorry, being smart, Alex.
I pulled up, I printed.
I think it's.
Go ahead.
Pardon?
Yeah, I think it's a matter maybe of time. Things will come. I think we just have to keep presenting and pushing and let them know that, you're not going to get rid of us that easy. Maybe as younger people get in, I've noticed a lot of times it's the same people year after year, and they're kind of set in their ways and they like their ways. And I think we have to get more people coming in as delegates and maybe challenging some of the ones that have been there for a long time. And I think then we'll see a little more change.
Well, and Susan, I don't mean to take over for you, but I think what really is important for us, before we even talk about what we've discovered, where we're at with this committee, what happened this week with ADHA is a huge lesson for all of our committee and everybody that's involved in the DCC. Now, we're talking about the particular thing for our work group, but yet what happened here is it was a great deal of positives that happened. First of all, I think, Michelle, you now see the value in not doing this as a Lone Ranger, but if for next year that we work together, the DCC, with our delegates to help bring forward to our house, because how the house drives the codes drive the house, all of those things work in concert. Does that make sense?
Yep.
Yes, it does to me. But like I said, this was so early on, and we have a
right, exactly. But it shouldn't. That's the whole thing too. Is we tend to do things at the last minute, and I'm not saying you. I mean, it's just the way. When you start something like this, it's like, well, the first time around we're kind of at the last minute. Well, we really didn't, as a group, understand this picture last year. So this year we first had Siobhan brought forward the thing to our committee, and then you brought it to our committee. Now, if we think about if we work on this, start now proactively toward next year's House of Delegates at ADHA, the difference we can make.
Right.
And that's the same exercise that we're trying to do here with affecting the codes by us coming up with the information and having our beginning parts of what we want as submission so that we can go out there and bring in other groups and potential partners. Now, with that being said, you actually, Michelle, you just contacting us, created a whole bunch of stuff. Susan, why don't you talk about what happened on your end and your connections, and I'll talk about what happened on my end and my connections.
Okay.
And some things that have happened just this week. And it was, Michelle, because you asked the question, congratulations, my friend.
I just hope I didn't do anything too premature and
No, you did it perfectly. You did it perfectly.
Right.
So go ahead, Susan.
So, yeah, I had a phone conversation with Brian Hill, who's founder of the Oral Cancer Foundation, this past week. He's been a friend and a mentor of mine for the last 9-10 years. And I told him what we were undertaking, and he said, I'm absolutely on, and he will do everything that he can. And so he is on board. And also, I volunteer with a group here in Denver. We go to Father Woody's. It's a homeless day shelter, and we offer free head and neck, oropharyngeal cancer screenings to the people that come in there. And we're headed up by a head and neck oncology surgeon. He is a member of the American Head and Neck Society. and he's trained at MD Anderson, just the nicest, best guy, and told him what we were doing. And he's absolutely on board with us. And he had some great insight. Brian Hill had said, because he's tried getting a lot of things through with some of the people we'll be dealing with. And he recommended that we stick with oral and oropharyngeal cancer instead of throwing head and neck in there, because sometimes that throws this group off, thinking too broad. But then Dr. Nemechek, who's head of the screening group that I volunteer with, he said, no, he said, I actually believe head and neck should be in there, because he said, look at all that you're doing. You're palpating the thyroid, you're assessing and evaluating a lot of different structures. It's more than oral and oropharyngeal. And he actually said, and this isn't set in stone, but he just said, what about head and neck, oropharyngeal risk analysis evaluation for tumors? He thinks tumors should be in there, but I mean, that's something we can discuss. It's kind of, throwing the horse before the cart here. Anyway, he had a lot of good input, and he'll be happy to come in on these meetings and, whatever that we want him to do. So that was my.
And, well, also though, what Susan and I talked about, Brian Hill, unfortunately, tell him about that and what we were talking about with even recording.
Well, I'm not going to tell that, because I don't know that that's to share for all.
Doesn't matter what there is, but there's a thing. Got it. Okay. But there's a thing about, with this subject, we've got to tap into emotion, not just logic.
Right.
I was just watching something on 60 Minutes, and the guy was talking. He was actually a judge at Nuremberg, and he was talking about, it's about the emotion of these people and making this situation a real thing.
Right.
And one of the things that Susan and I talked about before is, here in Chicago area, we did have our active walk for oral cancer, and we should maybe bring in people that they're survivors.
Yes.
What if at that committee they listened to survivors? And thank God they're the survivors, because that's the ones that can be there. So, I mean, what this did is it opened up all kinds of things. In addition, I contacted Michelle when you contacted me at 6:30 in the morning on Monday. I'm like, because I had to go out and do a program. So I reached out to Joanne Jones. Now, most of us know that name because Joanne's been around for a long time on this subject. And so she also had input and connections. This is where this really comes in, is all of these connections and who else we can reach to. And Janet, that's where there's a lot more there than you might believe, than you might have understood. But we need to look for these groups that are going to be, some of them are going to be natural allies, because the ideal is that when we submit, it's not just from the DCC. The DCC, the Oral Cancer Foundation, you see how that adds to even the validity from the first submission before it's even discussed at the Codes Committee? Does that help? Anybody?
Yep.
Yes.
Yes.
Okay.
And
then almost in a freaky, Larry, Michelle, he's from Poughkeepsie, New York. Larry, why can't I think of Larry's last name? Anyway, he is a dentist that was diagnosed with oral cancer about 12 years ago. I have not heard from him in about 5 years. I heard from him on Friday morning. It was almost getting freaky. And his group and his work, he is also willing to sign on, work with us, come and testify for us, whatever's needed.
Yeah.
So,
well, Patty, one thing that I did, because I was getting stuff from you and Susan and what was it, Brad? Is that, no, who's the other guy? Oh,
Brian,
I'm sorry. Bear with me. My head's still in a fog. And I got up and I said, and I gave them the statistics of how many people will be diagnosed and die and I says we are in a prime position not to save lives, not just prevent carries. Come on, people. It's like, I was trying to get to the emotions of people because this is, I'm not an expert at it. I do my oral cancer screenings, every single patient, but this is something I'm very much concerned with and, is passionate about. But so I thought I'd do that as far as, reaching out to the lives we'd be saving. But, back again. It's just all it's already in our scope of practice, or not our scope, it's already in our policy.
That was first time around. We'll keep going at it.
Okay.
We'll keep going at it. Okay, so now I think that was important for us to talk about because there was so many things that happened in connection with the important things that you guys were doing at ADHA. So Susan, why don't you go ahead and do the next part.
Okay, so back to where, here? Okay, so Janet, resources and potential partners. Who did you find?
I'm going through a lot. I had a really busy week, but I'm going through a lot of the oral surgery people that I know, seeing if they can hook me up with anybody. I have a appointment to meet with an oral surgeon that I've worked with in the past. I have an appointment with him Wednesday to see what kind of help he can give me, maybe with the Academy of Oral Surgery.
Okay,
Great, excellent.
Yeah. In any other that you found that we can connect with?
Like I said, I had a real busy week. I didn't get back till almost midnight, and then I had to work. So this week has been hell, getting back on track. But I'll have a little more time to get into things this week.
Okay, thank you.
Have you been in contact with Kim and the other person that's working on that subgroup of the you know what I'm talking about here?
I got a couple of emails and stuff, so we have yet to get together and actually sit and talk, but we've emailed back and forth a little bit here.
Okay, great. Terrific. And if you want to reach out to me for getting Larry's information or the other connections that I made with Joanne Jones or whatever, just contact me and I will, because my experience with this stuff is that it helps if it's not a handoff, hey, I want you to meet. It's more, let me introduce, this is the group, and you guys take it from there versus it all coming from me.
Okay.
Okay?
Okay. What
about within the committee itself? What about within the code committee itself and looking at the insurance carriers?
Let's see if we have.
You got to put it in the play function for that to work.
Okay.
You're not in play anymore.
Or not?
Oh, did it went? There we go. You know you are. It went. It looked like it came off, but it went. Nope.
Oh, I'm in the wrong part.
Left side, third one down.
Here we are. Code maintenance. Can you see? Is
No,
it?
no, you're there. That's it. Yeah, that's it. Not clear. Yeah, no, you're going. You're going. No, yeah, there you are. There we are.
So right here.
So scroll it down a little farther so we can see them. There we go.
Okay. So American Academy of Oral and Maxillofacial Pathology, American Academy of Oral and Maxillofacial Radiology, Oral and Maxillofacial Surgeons, Public Health, and then all the insurance carriers. Those would be good. What, Patty? Just Google those and find out Google who to contact at each association. See what comes up that way.
Usually on everybody's website, there's a contact thing. And even if we start with info, like on the first one, I'm actually on the page right now of the American Academy of Oral Facial Pathology or whatever the whole thing is. And there's an info at AAA, oh God, all these letters. Anyway, so it's a blind, info at, but if we contact them, what do we got to lose? Hey, we're looking to talk to the people that are in, about what we're doing, okay? We can also look, they've got position papers, look on their site for their position papers, et cetera, et cetera. Let's see. Go for it, Susan.
Okay.
Keep it going.
Okay. Does that help, Janet?
The other one.
No, right there. Okay. Alrighty. Patty, who else did you have for me to put on here? On this resources?
You know what? I'll send it to you.
Okay. Awesome.
And we have Larry Hamburg. We have Joanne Jones.
Okay.
We have others that I know.
Right.
I mean, from
All
Joanne, I got another lead on somebody else. So it's
Okay.
like it keeps going.
All right. You can send those and I'll put them in. All right. So let's see. Lucy, you sent a lot of great information.
I'm here.
Yeah, you sent a lot of.
Yeah, I just started Googling things and tried to read through a bunch of stuff, and I put a lot of the links and just captured a few of the statistics and things that the articles talked about from a lot of different types of groups. I wasn't exactly sure what I was doing, so I just tried to include a bunch of information. I mean, I certainly can keep looking or change how I do it, but there's links to the full articles. I just captured a little bit of the things that were interesting to me on the statistics, so that's kind of what I did.
Yeah, you sent a lot of great stuff, so thank you. Yeah, I was able to look through some of that, so that was great. So I put that.
One of the things I did. Okay, I changed the links on the Dropbox. Everybody should be able to go into and add to the Dropbox now.
Great.
Yeah. And then, and this is great. I'm looking at it now too, Lucy. This is awesome. And I think now it's thinking through and looking at things. What are the statistics that are important? What are the statistics that especially have changed that might influence? Because the other part we talked about with statistics was looking at if we can figure out the downline cost to carriers when it's missed.
Yeah, and I think there's one article in there that does, I have a link to, let's see which one it is.
Yeah,
there's one of them in here that has a whole thing about the cost to insurance carriers.
Awesome.
I can't remember which one it was.
Awesome. Yeah, that's the kind of stuff. Did you happen to get onto the ADA evidence-based portal?
No, I don't know. Can I get into that?
Yeah,
For
yep, it's
80
an open thing. And the reason why is that's when we use their stuff against them. You know, we look in there because that's the ABD portal is supposed to be we're all supposed to be doing things based on evidence and okay? And that might be another line of argumentation that we use. Here's the evidence. This isn't what's being, what's not being done, okay? But
Yep.
that's another resource. And that's true of any of the other associations. So with the group that's looking for the liaison, looking for the connections, if you also find something or they have something statistics-wise that can help the statistics group, that's how we make this work together.
Okay. So I can go back through some of these articles and then kind of try to put together some of the real specific statistics if you want. I just kind of highlighted some of them.
Okay, that'd be great.
Susan?
Yes, that'd be great.
There we go. Good job, Susan.
I was just finishing. I'm not a good multitasker. I was just finishing typing. I told you I'm a high.
If I can ask you back to Michelle and Janet, there was another resolution on HPV for the vaccine, and that also went down to defeat at ADHA, right?
Yes, I think it was Oklahoma who is in the middle of some legislation and needed support, and that too, it's all, because we already do some screenings. That's what it was, and then the fact that dental hygienists aren't going to actually be doing the screenings, but that the doctors will be able to do that. Excuse me.
But wasn't the policy is the American Dental Hygienist is in favor of HPV vaccines for girls and boys, for both females and males? Wasn't it something as simple as that?
Yeah, basically. I can put those in the Dropbox when I locate them, and then you can see what exactly was said. And they rejected everything. We brought everything back, even Oklahoma, and it's frustrating. I think that's why.
But this is part of the game. This is politics, guys. And
Yeah.
this is the same thing that's going to happen with coding. That's what I'm trying to get across here. Is we need to learn by what the argumentation was, even in our own professional organization. We're going to get that at the code committee times how much more.
Yeah.
Okay.
Right.
So what is it that we can
Tough
learn
enough.
from that experience of that rejection and bring it forward to bring different things or to spin it differently or whatever to our next effort?
Yeah.
I guess I was so confident that the laser policy went through that I thought, this will be easy. No. 2 years ago.
Legislation's never easy.
Yeah, it's interesting to me that they say they wanted to stay broad on it, but then there's specifics. And I printed out ADHA policy manual. There was something in there specifically towards screening for obstructive sleep apnea, then, the lasers, and it's like, really? And there's so much.
They pick and choose.
Yeah, there's so much on fluoride. It's like, give me a break. I was
right.
to say the least.
Janet, were you there for that discussion on HPV vaccine?
No, I wasn't there for that one.
That one. Okay. Yeah. Thanks. Okay, so moving forward.
All right. So evaluation codes. So this is, I wandered into a place I know nothing about, and I've been learning. So there are 9 codes under diagnostic, 9 evaluation codes, which all could in some way include, some do say oral cancer evaluation, but so here's what I found really interesting. On the DO 120, periodic oral evaluation. This includes an oral cancer evaluation and periodontal screening where indicated. Where is it not indicated? That's just, I was like,
I was waiting for you to discover that one.
yeah, I was just like, really?
Yeah.
Really? And then on the DO 150, comprehensive oral evaluation, it says, it is a thorough evaluation and recording of the extraoral and intraoral hard and soft tissues. And then the second paragraph of that says, this includes an evaluation for oral cancer where indicated. Again, when is it not indicated? Anyway, really? Okay. So there were 9 of those. And then we go to diagnostic codes. And this is kind of what.
Let me, before you move on from that, that's where I got to get. That was the compromise that happened when other people brought exactly what we're talking about bringing forward. That was the compromise that they came up with before.
Okay. So.
Okay. That was their idea of strengthening the language in the evaluation codes.
How is that strengthening? What was it before? I mean, where indicated?
The words oral cancer are in there.
Yeah.
The words oral cancer are in there, which was more than it was there before.
Oh, okay. But
I didn't say it was good.
Yeah, I don't. Yeah, the whole where indicated thing, it's like, do we only do where indicated for caries? I mean, anyway, we could all go on about that.
No, but see what you're saying here, Susan, this is exactly the kind of argumentation we need to come up with.
Yeah.
Okay?
Okay.
This is where the understanding of this, that was their again, do you see the wall we're gonna hit?
Yeah.
We're gonna hit it because they're like, well, it's already in there.
Yeah.
Yet one of the things about these codes is what is where indicated, where is that defined? And let me just throw it out there just for thinking. Would there were 3 caries risk assessment codes that were passed a few years back.
Yeah.
Should there be oral cancer risk assessment codes?
Yeah.
Is that going to be part of our package?
Yeah, that's something to think about, huh? Yeah. And then.
How does it hit the rest of you guys? Wait a second, Lucy, let me ask. Let's go ahead and ask everybody. How does something like that about oral cancer risk, head, neck, and again, I'm just going to use the shortcut, oral cancer, but how does that hit the rest of you?
Yeah, I think that's good, because maybe in the past, whenever that was passed, they were thinking of people were, it was indicated if you were a smoker and you drank alcohol, they might have been thinking that, but now with the causes being so different with HPV, there's probably almost anybody's at a higher risk today. I think the risk assessment would be really helpful because I think it would put most people into that group to be screened.
What's your thought, Janet?
I kind of like that because I kind of like the breakdown of the different risk assessment because there's risk assessment for all sorts of diseases, right down to genetic, family history, habits, socioeconomic. So breaking it down by risk assessment also might be a better pathway because we already have precedent of things broken down by risk assessment.
Right. Mm-hmm. Yep. And then
let's check in with that New York troublemaker. Ask everybody, Susan.
Yeah.
Michelle? Michelle, you still there? Come on, New York, where you at?
Says she's still there.
Yeah, that's okay. Let's move on then.
Maybe she stepped away. Well, you know, when you talk about those risk assessments, I was looking through the books here,
Still here.
and for Canberra, it says on there, takes away the age-based thinking that carries risk
That's
assessment.
right. There we go.
Takes away the age-based thinking that we're so kind of is in our thinking, and that's, I think that too works in our benefit, as far as everybody should have a risk assessment from their very first visit to their very last. That's, anyway.
One of my favorite books that I found when I was doing the courses on this more specifically was called Oral Precancer. Now, what I liked about the book is just in the introduction alone, the editor said the problem is that we're looking for cancer. By the time we find cancer, it's too late. We need to be looking for pre-cancer.
Right.
And it's just another way to take the language, and again, if we look at if I look at and just understanding who's on this code committee and the way I've watched them think, is they're only looking for disease. And so that where indicated is what? So what? We have to see a lesion? We have to do what, what is it where, even the definition of where indicated is nonsensical.
Right.
Would you guys agree?
Yeah, absolutely.
Yep. And some of the articles I found, they talk about that by the time we're finding it, it's stage 3 or 4, and then the costs of treatment go up astronomically.
Yep.
So that's good.
Yep. And that's where some of, the screening, the risk assessment, it starts with that health history questionnaire, asking those pertinent questions of the patients, trouble, difficulty swallowing, persistent pain, persistent ear.
But aren't those really all those things that bothers me about those is even on all those lists, whether it's from the whatever foundation it is, those are also advanced signs. By the time you can't swallow, by the time your teeth don't meet, by the time you have a sore that doesn't, those are still advanced signs, aren't they?
Well, they are, but with HPV, what they're finding is some of those are precursors before something's found on a tonsil, or before that mass appears on the neck, or the swollen lymph node. It could be extreme tiredness. There's a patient here in Colorado that goes with me to courses. He had HPV, oropharyngeal cancer. No signs or symptoms except for he was extremely exhausted. He could not drive the 20 miles home without stopping and taking a nap. And he went to his doctor, made an appointment. 2 days before he went to his doctor, a mass appeared on the side of his neck, just popped up. And the doc said, here, look at you, you're working too much, and let's give you an antibiotic, see me in 6 to 8 weeks if you're not feeling better. Well, he knew something wasn't right. The next day, he happened to break his toe at work, and he called the doc and he said, he's getting an appointment. Anyway, long story short, he had an HPV tumor blocking 80% of his airway. That's why, that's why he was so exhausted. He wasn't getting oxygen. His airway was blocked. So, and in work,
right, but isn't that also an advanced case?
It is.
And I think it is. I mean, this is what you just described, though, is the crux of the problem. Is we don't use risk assessment. We don't use the idea of until, again, we're looking for overt disease. And risk assessment is about finding it before there's any manifestation, because there's primary, secondary, and tertiary prevention. And when we look at it from that way, and that's how those codes, and that's how the Canberra codes. The other thing about looking at the Canberra codes is there is what we can play on with that is precedent. There is already precedent on this because they've created these codes. They've had these codes for risk assessment. But oh boy, I can see a beautiful argument on this sucker.
Yeah. But, you know, Patty, working with this head and neck surgeon, that's part of his risk assessment. Are these different signs and symptoms? Difficulty swallowing, exhaustion, weight loss, pain,
Right.
you know, difficulty chewing. Because a lot of times those are, even though the disease is progressed, those are things we're going to see. The patient's going to notice those subjective findings before anything is ever noticed as far as a lump on the neck or a chronic swollen lymph node or an abnormal tonsil.
Absolutely, absolutely. But there's other risk assessment that is what I'm talking about, risk assessment. I know that I carry the gene for colon cancer. My father and 5 of his siblings have had colon cancer. We have a first cousin that died of colon cancer, and we have found early squamous cell on my sister.
Yeah.
Okay, in a normal dental office, what would be done with that information?
Nothing.
Absolutely nothing.
Yeah.
Absolutely nothing.
Yep.
Now, when we talk about risk from that point of view, do I have any signs or symptoms?
No.
No, I don't.
But
if you're waiting for me to be really tired, for me to be really this or that, those are looking for advanced signs and symptoms.
Yep.
Well, and they're not going to make you wait 10 years to have a colonoscopy either. They're probably seeing you more frequently because you're at high risk. That's
right. Guess what I get to do on Tuesday, as a matter of fact. And I have Barrett's esophagus. And I have Barrett's esophagus and I have GERD. Tell me about my oral cancer risk, guys. It's huge, isn't it?
Yep.
I'm a high risk. Okay, this is what I'm talking about though with risk assessment. I'm not talking about where our teeth don't meet anymore and we're tired and we're this and that. But he had 80%, he had a mass that was closing off his airway. That's not looking at an early sign. Those are advanced signs of disease, aren't they? Now, a surgeon might risk because they're looking at risk to do the surgery, right? Aren't we talking about doing something a lot earlier with what we're trying to think through here?
Yep.
Yeah. But that's the system we have to challenge, in my opinion. By the way, this is why dental codology exists. This passion of mine for this stuff. Okay.
No, that's awesome.
Okay, so let's move it forward then. I'm sorry, I took us off on another.
Okay, so there's 9 evaluation codes. There's 38 diagnostic codes. For tests and examinations, there's 16, one of which is an HbA1c. So we're,
there's 2 of them for HbA1c. I gave you the old version. There's 2 of them for HbA1c now.
Okay.
HbA1c, but we also have a glucometer that also passed last year.
Okay. And then for oral path laboratory, it's there's 16 codes. So yeah, and it's like Patty said, one time earlier, we have all of these codes when something's found, but not for the risk assessment, the evaluation. And the wording is interesting, where indicated.
Mm-hmm.
Yeah. So that wording and what we present.
Have you been in contact with the other, Susan, have you been in contact with the other people on your work group on evaluation codes?
I haven't heard from Rhoda. I sent an email. I haven't heard from her. And then Michelle, I know was
Yeah, they were everybody ADHA. Michelle was doing her work for our committee in a different way.
Yeah.
Thank you.
We sure were, Michelle. All right.
So that is what we've got then, as far as that. Do we want to, Patty, do we want to get into intent tonight? What our intent is, what do we want from this outcome? You know, one thing that Dr. Nemechek said to me is the dentists are I can't say it. I'm having trouble.
Desensitized.
Not not what is it?
Oh, disincentivized.
Yes, thank you. Disincentivized. Because there's not a code for this. They don't have the potential to charge for this. And one thing he said is it is a complete separate procedure. It should not be thrown in with all of this other stuff that is in a comprehensive oral evaluation. Even the comprehensive perio eval has a code. The DO 180, that has its own code. And what's thrown in there is and oral cancer evaluation. Given where we're at with this disease, with this cancer, and it is on the rise, it is a separate procedure that needs its own code. Should it be charged for? In my mind, why not? Are we charged for other screenings? When I go into my dermatologist, I'm charged for my skin cancer check. Are we charged for our pap smear and for our mammogram and all of these different things? So
Got to watch when you say it that way, though, because you're making apples and oranges. Because those are specific tests. We have specific tests like that. When we're talking about a screening, are we charged for the screening before we have the actual mammogram and the actual pap smear?
good point.
No, but what's the answer to that?
Well,
what are we being charged for when we see that doctor on that visit?
Okay, so
are they doing a comprehensive?
Yeah, so I texted
evaluation.
Yeah, I texted my ex-husband who's a doctor, and I asked him. It says, and this isn't the mammogram, but this is the breast exam. Breast is coded separate, but under the same bill, as well as the pap and prostate. So they're coded separate, but under the same bill, unless they come in for abnormal problems. So,
Janet, I see your mic
on. I don't know. I was thinking kind of like when you go, you're charged for the office visit. I mean, just to walk through the door, there's a charge for the office visit.
yeah.
I don't know if that would really fall under the same thing as the initial screening. If it could be worked in with something like that, because before they even examine you, there's, the office visit charge, and then the annual gyno charge and the pap smear and everything's broken down. I don't know if that would be a pathway to put the screening in or not.
Right, because, okay, so we go into our physicians, they're going to have vital signs taken. Is oral cancer screening part of a vital signs? Of course, we don't even do that in dentistry, but anyway. Is that what you're saying a little bit there, Janet?
Yeah, kind of just the initial office visit fee, just, the charge that they charge you just because you walked in the door.
Right, and one of the things about dentistry is we are so specific to a commodity really commodified. It's a crown, it's a filling, it's a cleaning, it's a screening, it's a this or that. There's no aspect that we really have coding for our expertise. Whereas in the medical side, you get charged just for the time with that expert. Isn't that what you're saying?
Correct.
Yeah. So Susan, when you asked about the intent or the outcome, what are you seeking here?
Well,
Are you looking at, we want to get 3 codes, we want to get this or that, or do we want to have is it a behavioral outcome you're asking for? What are you asking for here?
yes,
I'm not clear.
yes. All of that. What, yeah, you know, what intent do we want? What outcome? Behavioral change? I mean, you know, yeah, that's always part of it, but then the risk, how would we do the risk assessment? How would that be coded out? So yeah, yes to all of that.
Michelle, let me ask you, when you brought that code forward to ADHA, what was your intent? What kind of outcome did you hope to have?
Just support of using advanced technologies or modalities or techniques for dental hygienists to perform oral cancer screenings. And that, of course, then we changed the name. It was just a support of, you know, moving forward in any kind of advancements with screenings. It wasn't about, some of the stuff we're talking about now, which is kind of good, because then if we need to rewrite it, it'll be totally different. You know, if you want to do early screenings or
well, the thing is about the advanced technologies, the thing about those advanced technologies, they're only, the gold standard that you start with is always head, neck, oral cancer screening.
Right.
That's still the gold standard. The others are adjunctives, and having, so the policy on hygienists using adjunctives, that's where a little bit, because we didn't get a chance to talk, that we're looking at, do we want, should the policy be on adjunctive, should the policy be on the screening, and does policy change behavior? And does a code change behavior?
So I'm sure we can come up with something totally different next year.
Mm-hmm.
So I just had a thought, because Patty, you always talk about coding for what we do. And if the language in the exam codes doesn't require an oral cancer screening, much less a perio screening on every patient, we all know there's people not performing those under the evaluation. So if we are coding what we do, then we really should be coding that we're doing the oral cancer screening, if we're doing a good oral cancer screening.
Mm-hmm.
So what we're really missing, and what you're saying there, I think it's really important, is that we're also missing a very important metric, a measurable way to know what's actually happening. All we have now is we have the outcome studies of where oral cancer is. But we can't really say, well, there's this many evaluations being done, and this is the outcome. Because do evaluations and early screening really affect? Now, they might know that in a research basis, in a ivory tower thing, but in a real practice-based thing, don't we need to have that metric in order to know, to measure outcomes?
Yes.
Yes.
Okay, good stuff.
Okay.
Anything else to add here?
Awesome.
Anything else to add to this one, you guys?
I'm going to do this from a very practical, looking at the carriers, to reduce not only the mortality and morbidity, you know, to change those numbers, but also to change the cost. It's costing a bloody fortune.
Right.
Mhm.
Beyond the cost on the individual, on the family. So it's more than just the morbidity, but it's the actual cost, numbers, and the other downline. I mean, because so much of the cancer therapies are so invasive that they cause so many other problems. So the costs just keep mounting and mounting and mounting.
Yeah, never ending.
So in the information that I gathered, if you guys go later to number 5, it's from the NIH.gov, and that whole article, I just have the conclusion there, but that whole article talks about the time, you know, when it's finally diagnosed, a lot of times it's stage 3, 4, and the insurmountable costs that it has. So that would be a good article for people to actually read the whole article.
Huh?
So that was number
Right,
5.
and then think about how you're going to use that authoritative resource as part of a submission to support what it is that we're trying to do, and the whys.
Yep.
See, Lucy, you got a lot more accomplished than you. Well, you didn't get a lot accomplished. Y'all did.
Yeah.
We just don't know we're accomplishing things.
Well, you see, but that's why this is. But you guys are, and that's what this is really. I mean, even in reading my experience at ADHA and coming up with policy, sometimes you go, oh, we just blah blah blah. But this is the actual way this stuff gets ground out. This is the way it really could and should be developed by a group of people realizing what we have as information, what our goals are, what our outcomes, and then how we're going to get there, and what parts of all that research that we're going to use. And we don't know what's going to be the most effective, the least effective, but we're going to have a lot of arrows in our quiver to talk to whomever it is that we need to talk to, because we might not use the same type of a answer to a carrier that we might do to the pathology people that we might use to the this and this and this.
Yeah.
Are there, Susan, maybe you know this answer, I know there were before, but what about some head and neck oral cancer support groups?
Oh, yeah. Get them on board? Absolutely.
Get them on board. Get the public on board with us.
Yeah.
Absolutely. Yeah, I've got some connections there. Good point.
I have a quick question. Are we including thyroid cancer in the head and neck cancers?
No, that's an endocrine cancer.
Right.
Okay. Yes, I know a lot of times the enlargement of the thyroid during a head and neck exam. So I was wondering if that was
well, we do
on the
assess
line, and
that.
we're not touching that one.
Yeah, we do assess that, but and you know, that's where Dr. Nemechek and I had some good conversation about this, and he said, yeah, you assess that for any abnormalities, but that's not actually a head and neck cancer. It's an endocrine cancer.
Okay.
Hey, I just wanted to mention when we were talking about the House of Delegates and all that, they're trying to get away from the House of Delegates and go to a General Assembly. And if that'll be the death of everything, if that comes to fruition, because at least the delegates have some invested interest and have some knowledge. But if you get just a bunch of dental hygienists, whatever area that conference is held at that time, and vote on something, it's going to be a clusterfuck. Excuse my French. So.
I think I've heard that. So what was the argumentation for a House of Delegates?
Oh, it's been in the making for a long time.
No, I know that, but what's the argumentation they gave for it? Why change it?
To streamline everything, to make everything so much easier, to involve more
So
people.
that we can have a body that just rubber stamps whatever the DOT does?
Yeah, uh-huh. Yeah. And they're getting away from the trustees, for districts. They're going to appoint people to
Really?
like they can appoint somebody from out west to be a trustee for out, on the East Coast, and it's going to be on merit. There's so many weird things going on, and that's why we're trying to stick together and trying to, elect people that aren't going to just rubber stamp and go with everything that, you know, that the head of the association. And I think we now have a male president, our first male president. He might actually be the down for all of us. I'm not sure yet. The jury's still out, so see what happens. But that's the direction they're going, and that's what they're calling the new governance.
Wow.
So,
Well, the reason I asked who they was because I think that's one of the things that I'm working very hard to get all of us realize. They only have the control and the power as long as we allow that.
Yeah.
We are they. If we're members and we're participating, we have a proactive say. And that's where what this group is doing, is being the proactive say on anything when it comes to codes that we can affect. And what we've got to be a little careful with is that we don't get too completely hygiene centric. Though our members are mostly hygienists, we also have dental assistants. We also have some dentists in our group. Not nearly enough, but that's where, again, this is because we don't need another thing where it's us against them in the mentality and in the thinking. And so, anyway, with all that being said.
Yeah, well, we do have a concern, so that's why they were only, when they present a slate of officers, there was one person for each office. And we're like, well, that's not a slate. That's not a choice. And so we changed standing rules and all kinds of stuff before we even got started so we could nominate from the floor.
Right.
And a couple of the floor nominees won over the slated officers. So, but just to keep a heads up that, things are changing and they're trying to change things. And for many of us, we don't think for the better. So.
Right. But then we also need to look at it then at how other people are affected by what we're doing. We're trying to change things too, aren't we?
Yes.
And there's many people that are thinking that it's not for the positive. Okay?
Yeah, but we're working for the good of the things.
Yeah, so this is really important. That's why I'm glad you brought it forward, Michelle, because we've got to look at when we're the change agents and the other people that we're affecting doesn't like the change, and how we are affected, how we feel when other people want to affect change for us.
Right.
Okay, it's all part of this game.
It's a game.
It is a game.
Yeah, it's a game of humans. It's a game of humans.
It's a human game.
Human beings.
I don't know if animals play this.
So what do we do next, Susan?
Well, have we covered all of these topics enough? Is there anything anybody wants to add into any of these that you could always email me if I need to add something here. I'll add more to these evaluation codes.
This is not a definitive list. It's just a working list.
Right.
Right.
It's just what we came up with at this particular meeting. So, okay. Yeah, great. Great conversations tonight, you guys. A lot of good sharing.
So what's next? What do we do next?
Well, let's keep working on more of this week. Resource and potential partners, statistics, valuation codes and wording, kind of how to look, and looking at how things are worded. Interesting stuff there. So I would say keep working on, in your groups, keep working on this and thinking more about our intent and our outcome and these things that we've talked about. Anything to add to that, Patty?
I have a quick question. So if we're talking about creating the risk assessment codes, where do we come up with the information that, like, say we have 3 levels of risk assessment, where do we come up with, how do we decide, or where can we find out how to decide what goes into those levels of risk?
Well, I know I've got,
Because I think the risk assessment is
yeah, I know I've
Good
got a
idea.
lot of information on that. I think Patty probably does too.
okay. Okay, good.
And again, using precedent that's already there, we can look. The thing is about the Carrie's risk assessment codes, they aren't that long ago, so we can probably find more information. Plus,
Okay.
if you remember last year, we had, I mean, it was earlier this year, but we had the Camper Coalition come on to our meetings, and they were especially helpful. They got a code through. Remember that? I don't know if you guys all remember, but it was like they had submitted a code that the name was like 2 paragraphs. It's like, that's the name of a code. Anyway, we were able to help them proactively at the meeting to craft it. And they said, if this sucker gets through, it's going to be your credit. And it's like, great, that's our credit then. I mean, not that it's about credit, it really isn't. But what we have is we have partners. That's another partner. Even though we might not think the Camper Coalition is our natural partner for something with oral cancer, this is what I want you to see, is that they are. Why? Because they've gone down this road and they've done the risk assessment codes. They have a body of knowledge, and the way they formulated it, maybe we can learn from them. Plus, the whole thing is, the whole philosophy of Canberra is about early detection and early treatment. When the signs and symptoms that we have traditionally looked at for cavitation and filling a hole, before all of that exists. So that's another one of those partnerships that I think would be really important for us to look at and connect with.
Yeah.
Okay.
Yep.
This is where it gets to be. This is where my out of the box stuff really comes in. Okay.
Yeah.
But that's what's going to make it work.
Yeah. Absolutely.
And again, Janet, that's your group. And if you want me, again, to connect you to some of these other players that I've been mentioning here, that's how we're going to move this forward. But it can't be all me. That's the whole thing. It can't be all Susan. And that's why we have these groups. And that's what's so important about it. And one of the things, and I totally get what you guys are saying about, you don't feel like you know what you're doing. That's what I feel about 99% of my life. Okay. I mean, we're just creating all this, and the thing that's wonderful about creating is the opportunity to create it however you want it. The challenge of being the creator of it is there aren't any rules or anybody else's framework, and particularly as hygienists, we're used to going along with somebody else's framework. We're the ones that are going to create the framework on this puppy.
Yeah.
What's
Well
help?
said.
All right.
Okay.
Let's move this. Because we've kept everybody for an hour and 20 minutes already.
Yeah. So just to follow up, here's what the form will be filling out to submit. And yeah, we all
Go back to that. Go back to that one for just a second.
Okay.
Take your arrow to the point where it says name. Do the first box that says name. What our goal we want to have is the DCC and blah, 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 blah. That's what I'm talking about. That's our first power move that when we actually submit it, that when the other members of the committee see that we've brought on, that's what I'm talking about with coalitions. Okay?
Okay. Awesome. Anything else on there, Patty?
Now the rest we'll get to later.
Okay. So remember, we all feel like we don't know what we're doing, but we are all human beings. Have questions, ask. Ask. And we're learning to fish. Patty's not going to throw us a fish. And if you haven't gone to that video, I'm not going to play it tonight because we're way over, but go look at that. It's kind of interesting. And there's, again, we went through the link to the ADA, the CDT codes books. I ordered the 2019 book. So when you don't have anything else to do, if you want to order a book, if you don't have it, really?
Well, you don't have. Today, anybody on this group doesn't have anything else to do.
Yeah, I know, right? And you know, I think it was at Under One Roof last year at your and Cindy's course, maybe, where I got your CDT 2018 shifts metrics driven book. Yeah, really interesting stuff. Because we don't learn.
What I wrote in there that makes them different than these other books, guys, is I give you the history. I try to give, whenever I sat in the codes committee, I record what it is the discussion is, and I try to put as much of it into those books. Now, I didn't start doing that until 2014, but 2014, 15, 16, 17, and 18 are in there. And remember, as members, you get 40% off, so it's all a good deal.
Yeah, really great book. I mean, I haven't read it all, but oh my gosh, just really interesting stuff. We don't learn that in hygiene school. At least I didn't. And just great information. So thanks, Patty. Okay, so Dropbox. Yeah, if you're having problems, contact me.
You shouldn't. I changed it.
Okay.
I changed it. No, don't start that precedent, Susan. We don't want to have that email stuff because what happens is we can't see it. And the idea is that we all are working with the same information. Now,
Well,
you put the stuff Lucy gave sent to you.
Yeah, I mean,
What?
if you need me to put it in.
Yeah, but I just changed everybody's thing that everybody can edit, so everybody can put it in.
Okay, great. Shouldn't be a problem then. Okay, so just remember,
I didn't know that, Lucy, so thank you, Lucy, for letting me know that.
Yep, so go to number 4, oral cancer, and click on that and add your stuff right there. And again, just a review of everybody else and all the groups. So our next meeting is July 7th. Wow, I can't believe it's going to be July 7th next week. And then, yeah, really? Oops. And then Sunday the 14th is the big DCC meeting. And what are you going to have us do at that meeting, Patty? What are you going to have us present?
Report. Yeah, report. Not present, but report. You know, this is what we've done together. So it's taking it from the small group into the bigger group so everybody else can hear what's going on with each of the work groups.
How specific do you want that to be? I mean, how
as specific as we have it at that point.
Okay.
Guys, you guys are doing fantastic on it, okay? Just keep going like you're going.
Okay. All right. So the meeting's recorded, so you can go back and listen to it, or for those that weren't here, they can listen to it. And it will be in there tomorrow. Wow. Awesome. Okay, so we're going to meet again on the 7th, 7 p.m. Central Time. Got questions? Patty's got the answers.
You know what? I'm going to take the screen for just a second.
Okay.
Because I want to show everybody exactly where to go for these videos. Okay.
Okay.
I'm trying to build this more and more for a resource for us. So here we are on the Dental Codology website. As an insider, you have access to the information in here. Other people do not. For example, I just posted a couple blog posts on silver diamond fluoride as well as Carrie's risk assessment codes. Hey, that might be something for you to go look at. Okay.
Yeah.
I'm just talking about those. So that's there. But here's our consortium replays. So now everybody's is in there. Our symbol for our group is this: Stop Oral Cancer. Okay. So what I'll have is I'll list it like this. That's the date. Then it has our group. So that's where you go and play the videos. And each group will have their own little symbol. This is for the provider language group. Okay. So if somebody needs to go back and say, hey, what were we talking about? That's our resource. Okay?
Yep.
All right.
Good.
I'm giving it back to you to close, Susan.
Okay. All right.
Are we done, Susan?
Yeah. Hey, thank you guys. Thank you for your hard work, for your expertise, and just for showing up and doing all that you do. It's really important. Appreciate it.
Thank you.
And have a good 4th of July.
Thanks for putting up with my voice.
Yeah, feel better. Feel better.
Thank you.
Happy 4th, everybody.
Yeah,
Happy
happy 4th.
Channel 7.
Yep. Talk to you next week.
Bye-bye.
Thank you.
Bye.
Thank you.
Good night.
Thank you.
Good
Bye.
night.
Hello.
Hello. Okay, I wanted to give you right away. I wanted to give you the. You have on your screen what?
So it's still up there, and
Okay, you need to end meeting for all. End meeting.
let's see, where does it say end meeting?
Go up in the just left upper left corner, usual kind of place.
Really?
Yeah, just go the X in the corner.
Oh.
You were making it too hard, girlfriend.
Oh, it's that easy.
That easy, yes, that easy.
Okay, yes, end meeting for all. Okay.
Okay.
End meeting for everyone.
Yeah, there
yes.